We are going to move forward to the presentation from Professor Datta from the Mahatma Gandhi Institute of Medical Science in India. He's going to speak about hyperthermia, a potential game changer in the management of cancers in low middle income group countries. So thank you so much, Professor Datta.
Thank you. Can you hear me and see my slides?
Yes, perfectly.
Okay, great. So good morning, everyone. And it's indeed a great pleasure to be again a part of this International Clinical Hypothermia Society meeting. And it was an excellent startup with Professor Bodes speaking on the various aspects of hypothermia, the challenges that we all have to face, and we have to join hands together. Now, so basically, he has perhaps touched more on the European aspects or the Swiss aspects, and I was fortunate enough to be a part of his group from 2012 to 2020, and I can understand the challenges that we had getting all this reimbursements approvals from there. So now since I moved to India, so I think I try to look at it in a different aspect altogether, and therefore I would like to try to see if hypothermia could be a potential game changer in the management of cancers in the low middle income group countries. So before we really go to the core topic, let's try to understand the ground reality of the LMICs, which I'm sure that would be important if you want to look forward towards hypothermia here. Now, LMICs, as we know, are actually the countries which have GNI, which is less than $12,695 US per year, as defined by the World Bank. Now, of the 216 countries in the UN list, 137 countries are actually LMICs, that is more than 60%. And these countries together, they constitute about 84.4% of the global population, that is 6.5 billion. Now, if you look at the cancer patterns in this particular LMICs, the cancer incidence as reported in 2020, it's 11.4 million, which constitutes around 60% of the global cancers. And if we go to the mortality, it goes up to about 71%. So that's the problem that the LMICs are facing. And then the parameter of percentage mortality versus incidence is around 61.7%, which means that out of the 10 patients who are diagnosed by cancer, unfortunately, we will be losing 6 or more in these LMIC countries. So that's indeed a great deal of challenge. So what are the causes that really contribute to this high percentage mortality and incidence rates in LMICs? Let's try to understand these. The first and the foremost, the locally advanced tumors. And these are really advanced. I mean, they go really beyond the T3s and T4s, which are used to see in the other side of the world. And just to give you a glimpse, this is what actually most of the centers in LMIC might be dealing on a day-to-day practice. Along with it is the lack of adequate radiotherapy infrastructure. And in 2018, only 33% of the population had RT access, and 51 of the 137 countries even didn't have any radiotherapy facilities. So that's the situation in 2018. I'm not sure if it has changed drastically. Well, if I now look at the additional teletherapy requirements, units that are required by 2013, it amounts to a staggering 12,000 plus teletherapy units. So that's the magnitude of the problem that is there in the LMICs. So if we leave aside hypothermia, there's a major problem of the lack of the adequate radiotherapy infrastructure. Now, if we can fulfill the need of a radiotherapy infrastructure, where is the manpower? And that's again another issue, the lack of adequate human resources. It could be for radiation oncologists, medical physicist, and the technologist. And then comes the issue of the reimbursement. Professor Bodis was talking about the reimbursements. And that's, I think, a concern in the European or the high-income countries. And as we see, the patterns of the health insurance coverage versus the GDP per capita, actually, the higher is the GDP of the country, the higher is the share of population which are covered by health insurance. And for those countries which are actually having a poor GDP, most of the patients have to share out of pocket the expenses of healthcare. So in fact, this is a double trouble. So therefore, the challenge in the LMIC is the locally advanced tumors, inadequate infrastructure, inadequate human resources, out-of-pocket expenses that the patient has to bear, and this really gives a feeling of despair in the eyes of these patients. And that's the challenge that we have to really deal with. So let's try to look at some of the common cancers that we have in LMICs. And here I first start with the head and neck. And if we look at the age standardized mortality incidence in the LMICs, 72% almost of the global cases of head and neck cancers are actually from the LMICs. And the mortality due to these is to the tune of around 81.5%, which brings the percentage mortality by incidence to about 38.2%. If we go to the second important cancers here, that is the cancer of breast, we find that the incidence of breast cancer is about 61% of the global population, mortality around 72%, and the percentage mortality by incidence about 36%. And then coming to the cancer cervix, another important disease in the LMICs, the incidence is 88% of the global cancers are actually from the LMICs, and the mortality due to cancer cervix around staggering 91.4%, and percentage mortality by incidence around 58.7%. So this is the magnitude of the problem that we are facing in the 137 LMIC countries, which constitute more than 72% of the global population. So if I just try to sum up these three major causes, the percentage share in the LMICs of the incidence is around 68.5. These patients' mortality is 79.7, and the percent mortality for incidence is 40.8. So that's really a major challenge. And it's not only the challenge of having these cancers, but the problem is, how do I really deal with these tumors? In any high-income countries would say straight away that just, well, they are deserving just palliation. But then the challenge here is I have to really pick up those whom I can cure from these extensive advanced tumors, which are bound to get palliated. And surgery, radiotherapy, and or chemotherapy would certainly fail to control such locally advanced disease. And therefore, there is a need to explore a different approach. So then the question comes that should hypothermia be explored along with radiotherapy and or chemotherapy, especially in the common cancers prevalent in low middle income countries? Well, if you look at the modes of action of hypothermia at 39 to 45 degrees centigrade, it is indeed established to be a potent radiosensitizer and thereby complements radiotherapy. It favorably interacts with the host of chemotherapeutic agents. It is indeed found to be even a tumor immunomodulator similar to an in situ tumor vaccinator. So a single modality of treatment which has shown to be a potent radiosensitizer, a synergetic action with a host of chemotherapy agents, and even a tumor immunomodulator. So hypothermia indeed is a unique therapeutic modality with multifaceted actions that could effectively overcome the limitations of radiotherapy and chemotherapy, and more importantly, without additional acute or late morbidities. So if these are what the properties are, then can these be really used for treatment of these patients? But then before we do it, as Professor Bodis was trying to highlight, do we have a level 1 evidence of using hypothermia, at least in these 3 key sites? Let's try to look at it. So now when we talk about level 1 evidence, we are talking about systematic reviews and meta-analysis that constitutes the level 1 on the evidence ladder. So if we have for head and neck, we had already shown that the probability of achieving complete response with hypothermia and radiotherapy increases by 25%. If we talk about local regional recurrent breast cancers, hypothermia added with radiotherapy increases by 22%. And if we look about cancer cervix, the locally advanced cancer cervix, a network meta-analysis, which is the highest level of evidence, has shown that the 3 top ranked interventions, in fact, out of the 13 different interventions which have been used to treat these patients, the first one, in fact, is hypothermia with radiotherapy, second, hypothermia with chemoradiotherapy, and third, a 3-week cisplatin chemoradiotherapy. So that's the evidence that we already have. But then that's not all, because we still have some way to go. What about hypothermia and chemoradiotherapy versus chemoradiotherapy? Because as we all have been practicing, chemoradiotherapy has been accepted as a standard therapeutic modality in locally advanced cancers. So what are the outcomes from phase 3 randomized trials? So let's see, this is a study which was published this year by 1 year in the International Journal of Hypothermia. And they showed that the overall survival and the local relapse-free survival. So overall survival significantly improves and the local relapse-free survival was not significant. And if you notice, there were actually 2 studies which were used, the Harima 2016 and Wang 2020. It was quite surprising for me that they missed out Mina's study, which I think is a very key study using chemoradiotherapy and hypothermia versus chemo-RT. So I in fact had to do a re-meta-analysis or trying to estimate again using the Mina's trial of 2019 reported for 2,202 patients. And what we found that now the local disease control improved by hypothermia along with chemotherapy by almost about 10%. And for the overall survival, adding Mina's trial, we found the overall survival also improved by around 5.6%, although it was just at p.07. So there was certainly a definite trend. So it means that hypothermia, even when you're adding with chemo-RT, would certainly help to improve the outcomes. Now coming to the other aspect is using a hypothermia with neoadjuvant chemotherapy, because this has not been so much studies. So in locally advanced cancer breast, which is again a common situation in LMICs. So we came across a paper from Laboda et al. From Ukraine, published in 2020. This is in fact a randomized trial of 2,200 patients, a neoadjuvant which uses a FAC chemotherapy along with hypothermia, and 103 patients compared to neoadjuvant chemotherapy alone in 97, followed by surgery in case of responders. And they used a 27.12 megahertz unit, which is a passive system. And this was the temperature distribution, which you can see pretty nice temperature distribution they achieved in tumor. And when we looked at some of the outcome results, you can see here that there was certainly a radiological response to the tumor response, and also the histopathological response showing infiltrated lymphocytes, necrosis, and microvascular thrombosis. And there was a significant improvement in terms of the tumor response, operability of locally advanced breast cancers, and survival at 10 years, which is seen here. Very clearly that NACT along with hypothermia certainly would help many of these patients to undergo surgery and thereby improve overall survival. At our center, we also try to use this particular approach, but we use single agent paclitaxel. And the histopathology surprisingly showed also a huge amount of intratumoral lymphocytic infiltration, presence of apoptotic bodies, and presence of tumor lysis, and even CD4, CD8 positivity of a 2+ positivity range. So it clearly shows that adding hypothermia along with neoadjuvant chemotherapy in locally advanced breast cancer certainly could be useful and calls for a phase 3 randomized trials. Now then comes the important question that how do we really deliver hypothermia? What about the hypothermia treatment delivery unit and what would be the optimal unit for LMICs? So some of the factors that need to be considered for this are that the unit should be affordable, the unit should be robust, it should be easy to use, it should be effective in all these common sites, and it should be in the approved ISM frequency for the country. And as we know, the entire world has been divided into 4 regions depending on these ISM frequencies. And if we look at the frequency range, we find that 13.56, 27.12, and 40.68 are actually available worldwide as an ISM frequency. Some countries in the region 1, subject to the local acceptance, that is mainly in the European region, have acceptance for the 433, and some in the region 2 have acceptance for the 915. So worldwide, it is this 13.56, 27.12, and 40.68 appears to be worldwide approved as an ISM frequency and can be also used for hypothermia. So if you look at the patterns of these particular frequency, 13.5, 27.1, and 40.68, we find the depth of penetration and the half depth power, that is 50% half power depth. For 13.5, it's about 6.6 centimeter, for 27 or 4.9, and 40.6 is 3.8. So which means that it really suits most of the tumors that we would like to treat in this part of the world. And most of these patients, therefore, would be indeed for the capacitive coupling plane weight matching, and this could really treat the tumors within these 2 plates, parallel plates that are there. The technology is simple, and of course, it needs a thermometry to measure the temperatures. So in recurrent breast cancers, we started this as a pilot study here. And this is one of the patients with the recurrent breast cancer trying to come up with all the patient has received radiotherapy, chemotherapy, and come with this big recurrence in the center of the chest wall. The patient was treated by 27.1 megahertz with a customized water bolus. And we tried to do a thermal simulation. And after about 6 months, we find that there is a complete response and the patient is doing absolutely fine. Similarly, this is another patient which I would like to share, the post-MRM recurrence. The patient comes to us, and what do? The tumor was about to fungate. There was no other choice, but we tried with our 27.1 megahertz short-wave hypothermia. And this is the dimension of the tumor, 11 centimeter by 9 centimeter with a height of 5 centimeter. So that's a massive tumor. We gave 1 fraction of hypothermia and 2 injections of paclitaxel. And at the end of that, there was complete disappearance of tumor. So it means that, yes, this works. This patient is currently undergoing treatment and is doing very fine. So therefore, to come into the final question is that could hypothermia be a potential game changer in LMICs? That's what we started with. I think we would agree that possibly yes, but then this is because hypothermia improves the outcome in all the 3 major cancers, the head and neck, the locally advanced breast cancers, and the locally advanced cervix cancers. But however, we need a cost-effective and a simple hypothermia delivery system that is cheap, suited to these sites, and less demanding on technical expertise. And of course, we need to conduct phase 3 randomized trials in locally advanced cancers, locally breast cancers, and locally advanced cancer cervix. And for this, as Professor Bodhi was saying, we need to collaborate. All the stakeholders involved need to collaborate, join hands, and perhaps that would also allow oncology outcomes, could help hypothermia even gain wider acceptance globally. So with these words, I would like to end my presentation, and I would thank my contributors from my hospital, from IAEA Vienna, from Mrs. Jory, and of course, Stephen Bodas. And thank you very much.
So thank you so much, Professor Datta. I think it's very interesting with your experience, not only with hyperthermia in more developed countries, but it's interesting the results you get in countries where you don't have all the things we may have in other parts of the world. And for me, it's very important that what you have just said, that the results you have are so good in so big tumors where you cannot give very high dose for radiotherapy, or the patient is not good for high dose chemotherapy, that is clear that hyperthermia is going to give good results in these cases. So for me, that is very interesting. And I think that I would also like to ask Carrie, I don't know if she is there, but maybe I think she can also give us some impressions from that part, because she is living like a similar situation, I think, in different countries. So please, Carrie, I appreciate your contribution.
Yes, Dr. Aragon. Can everyone hear me all right? Bit noisy?
There is a music behind.
There we go.
There is a music.
The neighbors. I apologize. The children are on holiday here, and they're playing noise in the complex. Sorry about that. I was in the process of typing a comment in the chat group. I was just saying, Prof. Datta, thank you very much for the excellent description of the challenges that we face in the low to middle income countries. We have a lot of challenges, and I do believe, from my experience, especially, that hypothermia has a huge role to play in these advanced cancers. Our challenges extend to the practicality of incorporating new treatments and the staff and the resources. And then, of course, we often have substandard treatments. The radiation is not, for example, we might not have your IMRT or 3D planning available in developed facilities. So our comparison, the addition of hypothermia to the substandard radiation treatments is another challenge, where it makes it difficult to compare the results internationally with the results in our countries with our radiation. But it's an excellent challenge to take on, and I hope we can get it right.
Yeah, so I have one question for Professor Datta, because I have seen the pictures where you have patients with ulcers in the skin with that. So do you have problems with the tolerance with that big tumors which are ulcerated? So are you treating them without any problems, or what do you do with them?
Yeah, actually, we have been treating them. We really don't have any problem. Because this 27.1 megahertz machine is available in any LMICs, most of the physiotherapy department would have it. It's very cheap. It's a fraction of the cost of the standard hypothermia. But it doesn't have a water bolus. So we designed our own customized water bolus here, and we just use it. And we have treated a few patients which have an ulcerative lesion on the chest wall. And I think by about third or fourth fractions of hypothermia, they start showing symptoms of healing. So we didn't have really a problem with that. Okay, yeah, that's interesting, because my experience is that the patients feel discomfort at that part with treatment. So it's interesting, because usually I think that a lot of people think that if you have an ulcer is contraindicated hyperthermia, because of that part of the skin is opened. So I think it's very interesting for me that those results showing that you can treat those patients with hyperthermia. So thank you so much. Thank you.